thank you for being here and spending your Tuesday night here at Hudson Alpha and here with me at HudsonAlpha U. I'm really excited about the next few minutes that we have together. I hope that we've created a little bit of intrigue by props in the front of the room. There's a subset of you as you walked in. You might have been handed a mystery slip of paper and asked if you would participate in some audience participation in a little bit. There's, if you are the owner of one of those pieces of paper, there will be no speaking, no singing roles doled out. So you can rest easy on that front. But we'll get to what that's all about in a little while. If for anyone who doesn't know who I am, I know there's lots of familiar faces in the room. I'm Kelly East. I'm the Vice President for Educational Outreach here at the HudsonAlpha Institute for Biotechnology. That's a lot of words. But we here at HudsonAlpha and HudsonAlpha Education really want to find ways to connect with the community and share with you what our passion is, which is DNA and genomics, and connect that to our daily lives. And so tonight's topic is all about DNA and disease risk and digging into what do we know about how our DNA informs the risk that we might get sick in the future, and what are the types of testing that's out there that's starting to become available now, but most certainly is kind of heading towards doctors' offices in the future that will help us better understand that. So that's where we're heading tonight, and let's go ahead and dig in. If I were to tell you that you had scored in the top 5% of all people that have taken a test, how would you feel? Proud, right? Yeah, you might hearken back to maybe tests that you took in school and college where that's a really good thing, right? That you are the cream of the crop. You outscored everybody else. And so that often has this kind of positive connotation attached to it. But what if I told you that test you took was all about your rather maybe trade that in for something a little more average? Probably so. And so, whether you want to be at the top end of a bell curve, right, depends on what it is that you're measuring, whether it is your aptitude for getting into college or whether it's your risk for disease. And clearly tonight we're here to talk about that disease risk side of things. I suspect, and there's a lot of familiar faces in the room, some of you might even recognize the back of your head in this picture up on the screen. At the front row, people are pretty consistent, right? You tend to sit in the front row. But this is a photo from a HudsonAlpha U event that we held around this time last year, where we were also talking about disease risk and kind of what goes into someone's risk. And we were filling up jars with puffballs. I see some nods. For the people that were not here and are thinking, what on earth have I gotten myself into? The jar model, or that we call it, is a way to think about your risk of disease and whether or not you're going to get sick. And to boil down all of that HudsonAlpha U into one slide, essentially, when you think about your risk for a disease like diabetes or heart disease or cancer, there's a lot of different risk factors that can go into that. Some of them are genetic. There's things in your DNA that control that. But there's also risk factors that are environmental. And so we were thinking about that in the sense of having yellow puffballs and blue puffballs that could fill a jar. And if your jar fills up, you get sick. That's the kind of the crux of the jar model. But there's different ways to fill up a person's jar. That you might have a jar that is filled up with one entire genetic risk factor. That by itself is enough to make you get sick. All right, that's an option. That's not the option that we're talking about tonight. What we're talking about tonight are diseases that are filled up with a combination of genetic risk factors as well as environmental and lifestyle risk factors. But even among that, you can have different sized puffballs or marbles or whatever you're filling your jar up with. Maybe there's one that's kind of big, but a whole bunch of small ones. Or maybe you have a jar that is getting filled up with a whole bunch of tiny puffballs or marbles, where each one by itself doesn't change how full your jar is very much, but if you could combine information about all of them together, then you could get somewhere with trying to figure out what your risk is, whether or not your jar is going to be filled. But that's really complicated because you're going to have to pull information from lots of sources, and you're going to have to look at lots of different places in your DNA to go look for all of those tiny blue marbles or puffballs. So that's some important background as we head into the types of genetic testing that we're going to be talking about tonight, which really is testing that's trying to find these and quantify them, measure that, and calculate how full a person's jar is. But there's lots and lots and lots of those genetic risk factors for disease. You are not supposed to be able to read this slide, so this is not a test of eyesight. In fact, the entire point of this slide is it's a lot of really small words. This is a slide, and this is actually a pretty old graphic. This is from 2015, so 10 years ago. This was a graphic that showed all of the different genes, all the genetic recipes in our DNA that affect or change our risk of coronary artery disease, which I'm going to be picking on coronary artery disease a lot tonight, just through the conversations that we're having, the examples, because that is a disease that we know a lot about because it impacts a lot of people. There's been a lot of research into it. But there are tons and tons of genes up here, hundreds of them. And this is 10-year-old data, so I guarantee now they would be, no one could read it. It would be so tiny if you were thinking about what are all the genes that have something to do with your heart and your risk of heart disease. And so to assess someone's genetic risk for heart disease, you've got to look at what their recipe says in all of these places. And that's really complicated because then you have to put them all together as well. And so that brings us to this term right here. And we very intentionally, when we were pulling tonight together, did not call tonight Understanding Polygenic Risk Scores, because I was afraid that we would have an empty room. Because this is a really big set of words up here. I could imagine it is quite intimidating. It's not all that complicated, but it sounds complicated, so that's why we settled on DNA and disease risk, because that's really what this is all about. But what we're going to be talking a lot about tonight is polygenic risk scores, which is a type of genetic test that can be done with the purpose of trying to pull, so if we break this word down, the first word is polygenic, where poly means many, and genic means genes. So this is trying to pull together information from not just one gene, but lots and lots of genes that are in your genetic recipe. So polygenic and risk scores. So this gets down to trying to put a number on what a person's risk is. How do they score? Right? Is it high? Is it low? Is it about average? How does that compare to other people or the kind of general population? So that's the purpose, that's the driving why behind doing a polygenic risk score. But polygenic risk scores in and of themselves could be done for any type of disease. So there are polygenic risk scores you can do for heart disease and polygenic risk scores for breast cancer. Right? Now, the genes they're looking at are different, but what they're doing is very similar, but a person's score is not going to be the same for both of those, right? A person's going to have a very different risk for heart disease than breast cancer because you're looking at different genes. So this is the textbook definition of what a polygenic risk score is. This gets into statistics, it gets into math. I promise I won't be teaching you how to do it because I can't. It's a statistical calculation that will estimate, it's not perfect, but it'll estimate a person's genetic predisposition, the genetic factors that might be putting them at risk for some particular disease. So that's what a polygenic risk score is, but what does it look like to get a polygenic risk score or a PRS back? Maybe you're thinking, well, okay, what does that actually look like if you were to have this test and you get a report back? And it can actually take several different forms. When you're thinking about telling someone what their risk of diabetes is, you could do that in a couple of different ways. And depending on the type of lab doing the test and how they report, it doesn't always look the same. And I wanted to walk through with you what the different ways of communicating that risk is, and see kind of, as you guys think about what it would feel like to get these risk scores, which one and which way resonates with you the best. And so one way to tell someone about their risk of getting sick would be as a percentile rank. This kind of gets back to that very beginning where I said, you're in the top 5%. Hooray. So this very much feels like that you're sitting somewhere on a, we often call bell curve, right? That's kind of what is pictured up here on these boxes, where a person has a percentile rank, but it's all about how do you stack up to everybody else. Where are you? If you're at 50%, if you're in the 50th percentile, that means you're very, very average. And anything higher than that means your risk is higher than most people. If it's lower than 50%, well, that means you're on the left side of the curve and your risk is lower than most people. Benefits, this is very visual. You can kind of visually see where you stack up. But you have to keep in mind that this is all just based on the genetics of that disease. And the diseases we're talking about aren't all genetic. And where you are on the curve doesn't tell you at all about what your lifestyle is or what your environmental exposures are. But this is one way that you can communicate or tell someone what their polygenic risk score is. Another way that some labs or some groups will report this out is as in something that we call a relative risk. In relative risk, everything kind of operates on a number line where kind of the typical person's risk is 1.0, and anything higher than that would be an increased risk. Anything lower than that is a decreased risk. So that's one way you could do it. This is really useful if you're trying to compare several different risk factors, like how much does smoking increase your risk for this versus having a terrible exercise routine, right? You can kind of stack things up next to each other and see what has the bigger impact on risk. And then finally, you could communicate someone's risk in what we call an absolute risk. And this is also reported as a percentage, but this doesn't compare you to other people. This is actually telling you your chance of getting this disease is this. So on a scale from 0 to 100%, how likely are you to get that disease in your lifetime? So in this particular example, 32% chance of getting that disease. If there were 100 people who had this risk, 32 of them would be getting sick. So 3 different ways to communicate that risk, to talk about it, to show it. And I would love to do something interesting with you guys for just a minute. And if you've got a smartphone or something, I would love for you to scan this QR code. It's no identifiable information. It's a 1-question survey that just asks you which one of those 3 ways of telling you your risk makes the most sense to you. If you were going to be getting a result back, which way would you want that said to you? And I'm going to give you just a minute to fill out that 1-question multiple choice, and then we're actually going to, it's anonymous, but I'm going to pull up the results so we can see what the room has said. All right, so what we're seeing up here, I know this is kind of hard to read, but if even from the back of the room, you probably see there's a really big chunk of this pie, 75% of it, and those are the people that are saying they like getting that absolute risk. Here's some, yeah. And I tend to agree because doing an absolute risk, you're able to actually take into effect those environmental factors as well as kind of how often, how frequent is this disease in the population. But there's also 13% said relative risk and 12% said the bell curve, the percentile. And I love that it wasn't a completely full chart of anything because it shows us that we all input information differently and have different preferences on what makes sense, what's going to be the most understandable. And so for those folks that are working in medicine and in research, perhaps we should be communicating multiple ways so that it's the most understandable to the most people, right? That we can present it as a relative risk and as a percentile. Now that absolute risk, the one that did win our very non-scientific poll that we just did, that one is the hardest to make because you've got to understand a lot about a disease to be able to combine not just the DNA risks, but also environmental risks and all that. There's lots of inputs that you need to be able to give an accurate absolute risk. And so most of the time, that is unattainable in terms of reporting out polygenic risk scores. I think we will get there, but there's lots of diseases where that's just not possible based on what we know today. All right, you can pop this back to. Okay, so we'll talk a little bit more in a few minutes about what do these types of scores look like when patients are getting these in the doctor's office or from research studies. But before we get there, let's talk about where on earth these scores even come from. What is the science behind them? How is it that we're even able to go figure out what all of those genetic risk factors are? The building blocks, the foundation of a polygenic risk score are a type of research study that is not new. We've been doing these types of studies for several decades now. If you've been following science and genetics for a couple of decades, you might have heard about these types of studies. And if you haven't, don't, again, let the terminology intimidate you. What these are genome-wide association studies. That we don't have to, you don't need to memorize that. We often call them GWAS, but GWAS studies are the bedrock. They're the foundation that sits underneath the ability to do a polygenic risk score. And what these studies do, what the purpose is to try to identify places in the DNA that are associated with a particular disease. They're trying to find the blue marbles, right? That's their job. And the ability to do testing where we are able to sequence a person's entire genome lets us kind of scan and look genome-wide for places that people who get sick more often have a particular recipe. So it works something like this, knowing that this is incredibly oversimplified from a graphics perspective. What genome-wide association studies do is they'll take a set of people, let's use diabetes, for example. They'll take a group of people who have diabetes, have been diagnosed with it. It's not a question of their risk, they've got it. And then a different population set of people who don't have diabetes now, right? Now some of them might later, but so they've got a group of people that do have the disease and a group of people that do not. And they'll look at this particular example. We're going to show two different DNA changes, but these types of studies look at thousands and thousands and thousands of spots in the DNA, and they ask the question, for a particular genetic change, does that change happen more often in people with disease than without? So in this case, we've got DNA variant, DNA change 1, and again, you're really doing this with hundreds, thousands of people, not however many are on the slide, but very simple. So on this example, we've got 6 on this side that have that genetic change. And in people without disease, maybe only 2 of them do. That feels different, right? That more people with disease have this DNA change than people without. So this, again, is not a very scientific example, but you could imagine that this change might be associated with having a risk for this disease on a much larger scale. On the flip side, here's a different variant, variant 2. And in this case, the numbers are about equal. So you find that genetic change at about equal amounts in people with the disease and people without. So there is no association between that genetic variant and that disease. Having it or not doesn't affect your risk. So this type of study is what we call genome-wide association studies, sits underneath polygenic risk scores because they're identifying what are the pieces of DNA that we need to be studying and trying to look at and pull together if we're trying to figure out what someone's risk is, trying to figure out how many risk variants do they have, right, and how much do they matter. This is a chart that came out of a paper that I was reading, getting ready for tonight, and this very busy chart shows how many of those GWAS, those genome-wide association studies, have been done over time. And you can clearly see that these types of studies have been going on since 2007 or before that. So as long as HudsonAlpha has been here doing research, genome-wide association studies have been happening, but they've been happening more and more. But also the number of people, the sample sizes, the number of people they're studying, and the number of genetic, the green is the number of genetic variants that they're testing, has increased dramatically over time as testing and DNA sequencing has gotten cheaper and faster and more accurate. And so what we know and our ability to find those genetic risk factors has increased dramatically over time. So that's how science has found the genetic variants. They found those blue marbles that are in the jar, but they're not all of those marbles in the jar aren't the same size as each other. Like I said, you have really, really big ones, medium-sized ones, tiny ones, and even among the little ones, you can have small changes in being bigger or smaller. And so before you can go out and try and give someone a score of how many genetic risk factors they have, in addition to finding what risk factors to look for, you have to also figure out how to weigh them. How big are they? Does that particular genetic risk factor double someone's risk by itself? Does it change it just a tiny bit? For the most part, all of these that we're talking about only change the risk a little bitty bit. But they've got to figure out what is their weight so that when they ultimately do the math, that they're assigning the right amount of weight to it. Okay. All right, buckle up. No. I studied science, not math, so I will not even begin to explain this to you. There might be people in the audience that are like, oh yeah, I totally understand that. I'm not one of them. But this is the statistical equation for putting together a polygenic risk score. At its crux, it is a sum, right, added together, a sum of all of those genetic variants that are adjusted based on how much they matter. Math happens. So polygenic risk scores are developed, right? And this is all done by super duper smart people and computers that are building all these different ways that you can put together information about all of these different pieces of DNA. But ultimately, there's a lot of trial and error involved in this. People that are trying to develop these models, they don't just develop one and go with it. They actually develop lots of models, different ways to put the data together. And then they'll go find a new data set that's not the one that they used to create it with, an independent data set, and they'll test it. They'll go out and say, I'm trying to build a polygenic risk for for colon cancer. So they'll go get data from a whole bunch of people with and without colon cancer and see how their model works, right? How does it perform? Is it better than random chance? Maybe they're onto something, right? And they'll model a bunch of different scores and see which one performs the best, which one is best at correctly picking out the people that have the disease and putting them in that high-risk category. And so there's all these levels of testing and training and validating a model before it's ever going to go out there and get deployed on patients in a clinic. And that is done typically with lots of different independent data sets so that you're not just teaching to the test, right? That you're going out to a new set of people and say, does it work in this group? Does it work in this group? Looking at different types of populations and seeing how it performs. And a polygenic risk score that does really well will put out data that looks something kind of like this, where if you were to take a population of people that you know their status, you know if they have the disease or not, and you put them through that risk score, that it would be able to pretty clearly separate the top 25%, the bottom 25%, and all the people in the middle, and that they would follow kind of discrete paths in terms of risk, that you could tease out the high risk, the low risk, and the average folks. That's ideal. Like, this is what a good PRS would be putting out data kind of like this. And that for the cases, the people who have the disease, that their entire bell curve would be kind of shifted forward, that there would be higher polygenic risk scores in that population compared to the people that aren't sick. So that's the under the hood, how we go from genome-wide association studies that have been going on for decades to now the ability to put those together into a score that has some validity, that's able to put someone on a spectrum of where they stack up compared to other people based on risk. But the question is, then what, right? If you know this information, why would someone want to get this information? What can you do with it? And where do we sit today? If you came in tonight saying, well, my doctors have never mentioned that I could have this testing done, that would not surprise me at all, because this is a type of testing that is not really in mainstream medicine at this point in 2025 for reasons that we're going to talk about, that where we're sitting, this very much is in the research space, but it's heading towards the clinical space as we learn more and more. But how could this be used? Here are some, we're going to walk through some hypothetical examples. Here's a hypothetical fake PRS, polygenic risk score report for breast cancer. And so this is something that a report could look like. This looks like tests that could come back from a lab doing 20% risk lifetime. So this is one of those absolute risks that people tended to like the most or think were the most understandable. So if a person has a 20% lifetime risk of breast cancer, that is higher than average. So for females, the typical risk is somewhere 12, 13%, 1 in 8 is the statistic that we hear and we say a lot. So 20% is significantly moved forward from that. So that's the absolute risk. If we were putting this person on the bell curve, they would be at the 93rd percentile compared to all people that would be taking this test in terms of where their risk stands. You can see how this would be confusing? That someone could misinterpret that and say they have a 93% chance of getting breast cancer? Yeah. No, they're just in the 93rd percentile of all people. Their risk is 20%. But that is an increased risk. And so what might someone do with this information? Is this something that would make someone change decisions? Should people at this kind of risk have earlier mammograms or more frequent mammograms? Should they look at things like lifestyle interventions and whether they're taking hormones or what their alcohol intake is or those types of things? There could be things that you could do to try to reduce this risk, not by going in and changing the DNA, but thinking about all the rest of the stuff that's in that jar that is changeable. So maybe. Here's an example report for colon cancer, so a different type of cancer. And for the following examples, they don't have absolute risks that I can tell you because, like I said, most diseases, it's really hard to get to an absolute risk. Breast cancer is one where there's a lot of data available and labs can kind of put it all together. But so this is reported as a relative risk, saying that this person's relative risk is about 2 times higher than the average population. So down here in this grid, I've kind of modeled what 2 times higher might look like in that kind of absolute risk space, but it's certainly not accurate or perfect. But in this case, the polygenic risk score is in the 99th percentile of all people, with a 2% higher or 2 times higher risk of colon cancer. So what could this mean? Does this mean that this individual should maybe have colonoscopies earlier, more frequent? Or if they have a colonoscopy and it's clean, should this person go 10 years before the next one? I wouldn't want to. What about things about diet and exercise and those types of things that also can modulate and reduce someone's risk for colon cancer? Could potentially be changes that would happen by knowing this information. Coronary artery disease, heart disease. You can automatically, just from the slide, see that we've now moved up into something that is way more common in general. So the average person walking around has a much higher risk of heart disease than any kind of cancer. But here's an example where, again, it's a 2 times higher risk based on DNA. And a risk score that's up in the 90th percentile compared to other people, so way at the kind of the tail of the bell curve. Coronary artery disease, are there ways to modify that risk? Yeah. Thinking about screening, maybe statins use, watching for early signs of disease, thinking about lifestyle modifications. Because all of these that we're talking about are not completely genetic diseases, that there are potential ways to modify the rest of that, non-genetic parts of that jar. What about Alzheimer's disease? Here's an example report of a person who, what this report is saying is that there's about a 2.4 times higher chance of Alzheimer's disease. And again, a percentile that is well up near the 90th percentile. But Alzheimer's as a whole is not as common in the population as something like heart disease. And so even though you've got a 2.4 times higher chance, the likelihood in your lifetime of getting it is still well less than 50%. What could you do with this information? Does this one feel different? No? I see some nods and I see some head shakes. I hear a no. And I appreciate that because that, just like we all think about risk differently and how risk is communicated to us, the way that makes us feel and what we would or wouldn't do with that information is also very unique and individual. Alzheimer's is, from a medical intervention side, is a little different currently in 2025, although the landscape is starting to shift and change. But largely, unlike with heart disease, there are less things we could do medically to try to reduce someone's risk of Alzheimer's disease. But what about lifestyle interventions? Things that would help keep brains healthy and help reduce risks that could be confounded with things like diet and exercise, and some of those things are known to help with Alzheimer's risk. So we could go all day thinking about different diseases and what might be done differently if someone knew they have an increased risk. And this is just a few conditions that have some polygenic risk score research that is out there around them. It's certainly not an exhaustive list, but the ones that we just walked through, as well as things like prostate cancer and diabetes, are in the scientific literature as studying how can polygenic risk scores be used to help people understand their risk and ultimately how to manage that risk better and keep people healthier longer. But just like we were talking about with those different diseases and what you might or might not do if you knew you were at an increased risk, just doing a genetic test is not the full picture of your risk. The genetic, your DNA does not work in isolation to either give you or make you develop or make you not develop these types of diseases that we're talking about. All of these diseases that we're talking about tonight are different than the types of diseases where a single DNA change makes someone sick, you know? So here at Hudson Alpha, we do a lot of research into lots of different types of human diseases. We have scientists here that are very interested in rare disease, where you've got a person, a child and an adult that has rare symptoms that we're trying to get an answer for, and we're trying to find a genetic change that is kind of a one-piece puzzle, right, that is fully causing that disease. We also have scientists here at Hudson Alpha that are studying things like Alzheimer's disease, which is much more complicated in most cases, where you are pulling together lots of different genetic risk factors, but also factors that aren't genetic as well. Again, it's very small up here, but it's a nice image that highlights the fact that genetics don't work in isolation. That a person's risk is controlled by genetics, but also the environment, also societal and lifestyle, and those things all interact with each other as well. You actually can't even think of each of those in isolation, that it is incredibly complicated. And even though we're here tonight talking about polygenic risk scores, so for polygenic risk scores and this type of testing to become ordered in a doctor's office, what would your doctor need to know to say, oh yes, I want to start offering this to all of my patients? If I was your doctor, I would want to know, well, if I find out that my patient's at an increased risk, what do I do, right? What are the guidelines? How do I manage someone with that risk that's going to make them more healthy, right? That's proven to improve their health and their life. And they're also going to want to know that adding that to what they're offering you is better than what they're already doing. Because yeah, in primary care offices all across the globe, doctors are trying to figure out a person's risk for heart disease. That's not new. How are they doing that today? Well, you fill out a lot of questionnaires, you answer questions about things like whether or not you have a history of smoking, whether you also have diabetes, whether anyone in your family has had heart disease, what's your weight, what's your current cholesterol level, right? They have those kind of inputs, and they are able to put all of those things together to try to guess and estimate what's your risk. So they're already doing that. And so an astute physician would say, well, okay, this sounds really good with polygenic risk scores, but is it any better than what I'm already doing to try to assess risk? And so the chart that's up on the screen, the different risk factors I just read to you are all in a line. And the way that this data is measured and shown, it's something called a C index. You know, we're not going to get into a lot of statistics, but in essence, the higher that number is, the more accurate it is, right? The better it is at predicting a person's risk. And so smoking all by itself is not so great. Like if you took no other input than that and tried to estimate someone's risk just based on their smoking status, that doesn't do such a good job. Down here, this line right here, come on, that shows where polygenic risk scores, how good they are at assessing someone's risk. So it is better than all of those other pieces looking at each of them by themselves, things like BMI, hypertension, high cholesterol, right? Polygenic risk scores is a better risk assessment. But what it's not better than is this line right here that says conventional risk factors. And what that means is that is an existing risk score that is based on all of these things right here. So if you roll up a person's information for all of these, and that can give you a score that is way out here. So that's what they're currently doing. That is kind of standard of care right now. This line here at the very bottom that outperforms everything is conventional risk factors plus polygenic risk scores. So adding polygenic risk scores to the types of risk assessments that are being done does make an improvement in accuracy of telling someone where their risk stacks up. So that goes to show that, yes, this is valid. Polygenic risk scores are, they're not perfect, they're an estimate, but they can pretty well improve, at least in diseases like coronary artery disease, can improve someone's risk assessment by using that in addition to the other types of risk assessments that are being done. So polygenic risk scores can be valid, they can be accurate, they can be correct, but for things to really hit the clinic and become widespread, it needs to be more than just valid. It needs to have this term up here called clinical utility. And that's a measure of, is this test useful to a doctor and a patient? Will knowing this information not just be interesting, but can it actually be used to make someone healthier, to improve health outcomes for patients? And that's a much higher bar to cross for any kind of new technology, and takes a lot more work and research that takes a long time to do. And so this really is a major limiter right now to this type of testing becoming widely used. That for a physician, there are really no good guidelines out there for them to know who to offer it to and what to do with it if they get it. There's no guidelines for them to work within, not because we don't want to create guidelines in medicine, but because all the evidence that is needed to be able to develop those guidelines is still in development. So studies like this one, this is one of many, but this is a study that was published recently. It's called the MI Genes or Michigan Genes Study, and it was looking at coronary artery disease. And what this study did was it took sets of patients, took 100 patients in both arms of the study, so about 100 people, they were given conventional risk scores, right? So that's the scores that's just based on smoking and BMI and cholesterol levels and all of that. And then the other half, another 100 patients, were given a score that includes all of that, but also includes polygenic risk. And then they tracked them for 10 years. So you can imagine, like, this takes time for this to develop and for the evidence to build. So they watched them for these groups of individuals for 10 years, kind of stalking their medical record. And here's what they found. So in the group that just had conventional risk assessment, of those 100 people, 9 of them ended up with major bad adverse cardiac heart events. And nearly half of them had a test that was aimed at trying to diagnose coronary artery disease in 10 years. Meanwhile, the group that also got polygenic risk scores only had 2 major adverse cardiac events in those 10 years, And only 29% had a test to try to diagnose heart disease. They also had more statin therapies being done in that group and overall lower cholesterol levels, which is a major risk factor. So this is small. I mean, it's 100 people in both arms. You can't create medical guidelines after one study. And this isn't the only one that is in process or been done, but these are the types of studies that will be needed to kind of shift that and to create guidelines that then would make these types of testing usable in actual clinical practice. Another limitation, and this is going to kind of lead us into the active portion of the evening. Another limitation, something that we certainly, as these studies are being done, needs to be paid attention to, is polygenic risk scores are only as good as the data they're based on, right? Those studies that are at the foundation of them determine the accuracy of the risk score. And when you think about the populations that were studied in genome-wide association studies, what do you think? It's not very representative. And so this is a chart looking at those studies that are underneath polygenic risk scores over time. So at this side of the chart, we've got 2008, and over here it's 2017. And I suspect this trajectory has continued fairly in a similar trend since then. And so it's looking at all of the different studies and the populations of people that were being studied. And the blue at the bottom, those are individuals of European ancestry, which has made up the bulk of genetic research over time. But you can see over time that has improved, but is still far from representing the world's population. And so there is very valid concern that taking a polygenic risk score that was built on data in Europeans and then applying that risk score to other populations, that the accuracy falls off. Not completely invalid, but it's not as accurate, and the data shows that. This is a more recent study that is looking at polygenic risk score accuracy, so going up and down from bottom, this is really not accurate, and up at the top, it is highly accurate by population. And who's up at the top with the most accuracy? European populations, and it goes and it trails off, and which is what we would expect. But it's something that needs to, as this is getting more data, as we are moving towards a place where this is going to be more common and standard of care, needs to be addressed before it could be rolled out to large populations of people for clinical purposes. Okay. So let me introduce you to the boxes up here. The boxes to my left are far more colorful than the ones up on the screen. But to orient you, this looks like a bell curve, right? A standard curve where most people are in the middle and you've got two arms on either side, right? Where it's less people are on the extremes. This could be, the most recent science test grades. But in this case, this is disease risk. And so across the bottom is the percentile risk score. So we are operating in a situation where we can't do absolute risks. We're going to be measuring people based on where they stack up along this curve. That a person is either, they could be in the 5th percentile, which means they're way over here. They could be at the 95th percentile and they're way over there. If they're at the 50th percentile, they're somewhere in the middle. That's where most people would be. And so each of the columns of boxes is a range of polygenic risk scores. So this very short column over here, this is a risk score between 0 and 10, 11 to 20, 21 to 30, and so on, all the way across, where at this end, these are polygenic risk scores in the 80s, and then this is between 90 and 100. So that's how that kind of tracks. The colorfulness that is up on the screen now, but also on these boxes that are here in the room with us, is a measure of the data that has gone into this polygenic risk score and is showing what proportion within each of these risk categories did the data come from people of that ancestral background. So there's a color code up here where the blue, kind of like the previous slide, the blue sections would be individuals of European ancestry, the orange sections are individuals with African ancestry, and so on. And this is a pretty colorful chart here. So the people who developed this did a really good job of representative populations. Okay? So there are a number of folks who, as you were coming in tonight, were given a little card. And that card was not meant to represent you. This is more about you representing a hypothetical person. And so on that card, if you've got one, you should have a name of a person. You should have their age. It should tell you what that person's ancestral background is, whether it's European, African, Middle Eastern, Asian, right? That there is a predominant ancestral background for that person. And it gives you that person's polygenic risk score for heart disease. It's a number. Up here, there's a couple examples where this person, congratulations to Jordan, who has a coronary artery disease polygenic risk score of 12. This is, again, like you want low, ideally. But there's also a 56 right here for Angel. So what I would love for you to do, if you got one of those cards, is just real quickly, I'd love for you to come up here. Again, no song and dance, but we're gonna hand you a Post-it note. And I wanna see if you can put a Post-it note here on our boxes in the place that both represents that score and the ancestral background. Might be a little chaos for 3 or 4 minutes, but let's see if we can do it. All right. Y'all did a good job. Everybody found a spot on this chart that both represented your person in terms of their background as well as where they stack up. There are kind of a wide smattering up here. There are some that are low, that are in the 10 to 20 range. There's quite a few that are there in the middle, and there's some that are up higher. But all of these individuals that we were charting up here, they were represented in the data, right? There were groups of people like them that went into the making of this polygenic risk score. For those of you that did that exercise, would you have been able to put your Post-it note on a set of boxes that look like this? Some of you probably are thinking, yeah, absolutely, no problem here. I'm guessing that the people who had individuals that are of European background were like, yeah, no problem. I'm still represented in that data. But others are like, no, like, you can get that data for this person, but they're not represented in the data that score came from. So clearly, we as a collective science have work to do for this kind of testing to be the most useful for everyone, both in doctors knowing what to do with it, for patients knowing what to do with it, and for the scores to continue to get better because the data that's going into them will get better. So thank you for jumping in and doing this. I want to call attention that we didn't just develop this idea for tonight. It's actually modeled after a hands-on kit that students are doing in their high school classrooms all across the globe. So HudsonAlpha, our education team, develops classroom activities, and one that we developed over the last few years is all about polygenic risk scores. because there's a lot of power in this, right? Students need to learn about data. They need to know how to graph things. And I bet when they become adults, their doctor's going to be offering them a polygenic risk score. So there's also a whole lot of just public education, future public education happening, doing this in classrooms. But you can see in this picture, this is a tabletop. So in a classroom, we are not giving teachers 30 U-Haul boxes to assemble in their classroom. No, there is a tabletop version that's done in classrooms that has a whole lot more steps to it than we did tonight. But we're really proud of this, and the shameless plug is that this activity actually won a Best in STEM award last year, all about being a great way to teach students about data. So that's the, yeah. Okay, so as we kind of pull things together tonight, if I could say, here's what I would love for you to walk out those doors tonight knowing about polygenic risk scores. Because we've talked a lot about what they are, how we got them, how they can be used, what their limitations are, is that polygenic risk scores are all about risk. No one's going to do this test to find out if they have diabetes. Like, this is not the test for that. This is a test that could inform someone kind of maybe what their risk is for getting diabetes in the future. So it doesn't make diagnoses. It's about future risk. That there is no score that you can get on a polygenic risk score. You're never going to get a 0 and you're never going to get 100. Because at no point can we completely rule out the chance that you might develop some disease. And it also is not going to absolutely guarantee it, because genetics for no disease that we've been talking about tonight is genetics the whole story. So even a low score, even some of these lucky folks that are down here in this 10 to 20 range, some portion of people who get low polygenic risk scores are still going to get sick. It's just less likely. And so a low score doesn't rule it out. And so there is some concern about what if people get this type of testing and then they're like, oh, I have a low risk for breast cancer. I guess I can just skip mammograms the rest of my life. Would not be a good outcome. And so there is research also being done about how do people behave when they get a high risk? How do they behave when they get a low risk? Would we potentially be creating a situation where people are over-interpreting their low risk and not doing basic things that they should be doing as far as just general screening guidelines? This type of testing is best for these types of diseases we've been talking about that are really common, they're complex, they're caused by all of those tiny little marbles or puffballs in the jar. This type of testing is not going to pick up a genetic change that's really rare in you that has a really big impact on your risk. So for example, in Alzheimer's disease, there are certain families, there are certain genetic changes that dramatically increase someone's risk for Alzheimer's disease, where it's passed down from generation to generation. There are families with those kind of single one-piece puzzle forms of Alzheimer's. This test would not find that. It is not meant to pick up rare changes. It is about finding common changes that change your risk by a little bit, but if you can mash them all together, you can get somewhere with it being informative. Polygenic risk scores are most accurate when the data behind it is representative of the person being tested. That's what we were just talking through. And that currently, there are very limited guidelines for how this type of testing should be being used out in general medical care. So that is kind of where we currently sit with polygenic risk scores. But you can see the momentum building, right? The research studies are currently being done trying to figure out how can we make these better? How can we actually use these in the clinic? How do we test how this needs to be done to where I think there is a future time where this type of testing is far more commonplace. So what do you do next? Walking out of here tonight, that's a personal question. I can't answer it for you. But as we think about kind of, as you've sat here and listened and thought about polygenic risk scores, here are 3 possibilities by representation of emoji of how you might be feeling and what you might think about next steps based on those reactions. So this is a very excited emoji over here that might be thinking, wow, this sounds pretty cool. And I think this is something that might be really useful and interesting to me, because I would love to kind of dig in and see if there's some things that I would want to do differently about my lifestyle, my environment, and how I think about my risk. So maybe you fall into a kind of early adopter camp. Or if you're like, no, I want to jump in and see what this is all about, despite the fact that there's all these limitations that if you take a score to your doctor, they may not know what to do with it. But if you find yourself in a place where you're like, I'm curious, this sounds interesting, and something that might be useful, this is testing that can be done today. Places like our clinic here at HudsonAlpha, the Smith Family Clinic for Genomic Medicine, does order this testing, albeit not a lot. But there are people that come in and say, I want to know everything I can about my risk. I get that there's not great guidelines. I get that this isn't covered by insurance, but I want to know more about it. That is testing that can be done. So I don't want you thinking that this is completely out of clinical care, but it's certainly not mainstream. But if you do want to explore that further, our clinic would be a place that you could go for that. But maybe you're sitting there thinking, well, this sounds really interesting, right? Maybe you're the nerdy emoji. I mean, you're here on a Tuesday night, so maybe we're all that. But that this is interesting, and you're anxious to just continue watching this and learning more about it, and maybe even to try and think about how can you help drive that data forward? How can you help that momentum move so that we can get to a place where this might be useful faster? And so most polygenic risk scores right now are definitely sitting in a research space. There are groups trying to figure out, how do people understand this? How do we communicate risk? How do people behave when they get it? How do we build those data sets up more broadly? So a couple of kind of practical things I can point you to in that sense. You might, if you follow HudsonAlpha on social media or in the news, HudsonAlpha does lots of research into lots of really important problems. One of those is Alzheimer's disease. And so there is a research study called HOPE-AD that has been recruiting here through our clinic. That it is not a study that is all about polygenic risk scores. It's actually a lot bigger than that. But as part of that study, we are actually doing polygenic risk scores for Alzheimer's disease for the population of patients in that study, and starting to look at and do our own research around what does that mean, what are we getting, how are people reacting to and feeling about that data. So that is something happening at HudsonAlpha that does lean into polygenic risk scores. But beyond that, another place that I often will tell people to go that are interested in whether it's polygenic risk scores or it's any other disease you're interested in, is a website called clinicaltrials.gov. And this is a government website where every clinical trial in the country has to be registered. So it's a great place to go get a good read on what's happening, right? And so I tried this this week. I went into clinicaltrials.gov and I put in polygenic risk scores. And it pulled up a whole bunch of ongoing studies across the country that are digging into it. And so whether you're wanting to see if there's a way to plug into those studies, or you just want to know what are we researching, people who identify with that emoji friend right there. Or maybe you're like, hi, I don't know, this sounds a little bit futuristic. This feels like something that, yeah, maybe one day, but there's still a lot of steps we've got to get to before this is something that might be really broadly useful. I think that's a very fair sentiment and reaction to polygenic risk scores right now. Where people might be thinking, okay, I'm glad to know this and where this currently sits, but I'm going to watch and wait and see where we go and wait for those things, that clinical utility, the usefulness of this to get better established, and for doctors to know more what they should do with it, and then engage with it at that point. Totally fair. I do think we will get there, whether that is 5 years from now, 10 years from now, and it's going to be different for different diseases. It's not going to be a sense of where it's going to turn on and all of a sudden you're going to be able to go out and get all of your polygenic risk scores, because where we are with each of those diseases is different. The evidence is showing that coronary artery disease might be the first that gets those guidelines kind of figured out and established. It could surprise me and be another one, but there's several that are really there's a lot of research being done around. But yeah, I think whether you're like in the early adopter camp, the I want to follow the research camp, or the we'll wait and see, are all very appropriate reactions to this information, and is a sense of being informed, right? An informed consumer of the news, and of medical care, and what you would be asking doctors for or reacting to being offered. So with that, we would not be here tonight without our sponsors, so we're very thankful for their support and letting us be here at the Jackson Center with Jackson Center cookies, right? And also, as we're wrapping up, I hope that everybody in this room, if you have come to one of our events before, and if not, we now know you, and you will be, are getting emails from us through our Alumni Association that anybody who comes to our things becomes part of our alumni, and that's a way for us to stay in touch and keep you up to date with the things that we're doing for the public, but also the things that we're doing with teachers and students and interns, and ways for you to keep informed and continue to support us. So this is the last HudsonAlpha U for 2025. The next event will be early next year in February, where we'll be back here at the Jackson Center talking through a whole bunch of really cool cutting-edge discoveries that are being discovered this year in science labs across the globe. So I hope that you'll come and join us on February 24th. And with that, I hope you'll have a great rest of your evening, and just thank you again for spending it here with us.